it's evidence-based. It's evidence-based industry, and I'm glad the recording's here just in time to hear this out.
Sorry for
Um,
that. My bad.
no problem at all.
Even
Um,
later than Andrew joining.
What's that thing that's better than never?
Well, so I mean, there's survey data, but there are actual studies that are being done of ambient AI, and in particular with our product, um, with academic medical centers such as University of Iowa, Iowa Health, who've done studies looking at clinician burnout, where there was over 25% reduction in burnout in users who have embraced Nabla. And so it's asking the actual users, asking the patients, looking at the EHR data and collecting all that so that we have actually real quantifiable metrics that show the value that we're bringing.
Nice. Thank you. Thomas, same questions. What does Awell do? How do you create value for whom, and how do you capture it?
Yeah, so I like it that it starts with his mission. It's for us, it's we want to make care flows work harder than care teams. So a care flow is essentially a workflow in healthcare. Somewhere in the care continuum, there is a workflow that likely is not so productive, not so efficient, that has a lot of manual back and forward. And it's our mission to help our customers, so provider organizations, to turn those inefficient workflows into things that work better, are more effective and more efficient, right? So we're essentially a toolbox, so our customers have access to our platform that allows them to create these workflows, to test them, then to bring them live, to integrate them into their EHRs, into their CRMs, into their point solutions like text messaging, emailing. There's a lot of voice AI going on at the moment that we orchestrate, which we'll touch upon later. So we are very much this, broad toolbox. So it's difficult to capture Awell kind of in one bucket. The types of flows that are most, the killer use cases, let's say, go from everything pre-visit to post-visit. There's pre-surgery, post-discharge, chronic care management, lots of referral flows. So it literally spans the whole spectrum and all of the stakeholders involved. So these flows sit essentially between patients and care teams and drive the activities and the tasks for those human stakeholders, more and more for the AI stakeholders, and also for the systems involved, which is just passing data around. The results that our customers drive kind of sit in two buckets. One you would say is operational excellence. The other is clinical excellence. So operational excellence is still the biggest bucket. Think of this as teams wanting to see more patients with the same team, or drive down inefficiency. So indeed time spent per patient, drive up utilization rate, all of those things, like patient throughput. I mean, many organizations have many different words for it, but it's all related to increasing the capacity of the team to handle more patient flow. And then the clinical bucket there, clinical excellence, is obviously outcomes. Personally, I'm disappointed that we're not yet further on the value-based healthcare train, where teams are actually measuring and improving outcomes. Although some of what CMS is bringing in the US is very interesting at the moment, but we have teams who regardless of the absence of financial carrots and sticks, drive clinical outcomes with these flows. One of the most visible examples is a customer who published research that they, in lung cancer, with their lung cancer care flow, were able to almost double the number of patients that were still alive 1 year after follow-up, where they drove down readmissions by 30% and other clinical factors. So the way that we capture value is we charge our customers per monthly active patient. So we're kind of almost an infrastructure layer. As soon as a patient is active, so that our platform orchestrates something on behalf of that patient, that doesn't even have to be something that the patient themselves are involved in. Could be synchronizing something with EHR, or running an AI action, or sending out a text message, or creating a task for a care team. None of those tasks essentially directly involve the patient, but it marks that patient as active, and we charge per monthly active patient. How we want to be a part of the solution and not of the problem is that whether our customer orchestrates a single activity for a patient, or a million in a given month or more, we charge exactly the same per monthly active patient. So there's no tax for orchestrating a lot of activities per patient. That's how we capture some of the value we create.
Nice. Thank you. Rik, you mentioned Sword, what Sword does briefly, but if you just want to round it out.
Yeah, I will try, and I will try not to bore you to death about it as well. So Sword essentially is it's a 4 billion organization. It's a massive AI care company that started into the MSK space, then expanded into women's health, mental health, is expanding into more and more of these disease areas. And what we always do is we have an AI portion that takes care of patient engagement and all of these things, and then we have a human portion. So we have humans in the loop, clinicians, physiotherapists, psychologists, like we have many clinicians on staff. And so over the past 10 years, they have built quite a lot of technology to scale our own care model. So instead of like a PT seeing 50 patients, it's like well beyond that. And so what we do with our intelligence is we take the internal tooling that we have developed in-house to scale our own care processes. So like AI agents to do care management, to do engagement, to do appointment confirmation. And we sell them as off-the-shelf tools to governments, big insurance companies, and also big health systems. Um, and the value, or how we capture the value, is like the way that we go into a hospital, because we have like 10 years of R&D, we have quite some tooling available in-house. So essentially what we do is we go to the hospital or we go to the insurance company, we spend an insane amount of time with them to deeply understand like what are the problems that we need to solve. And then we just look into our toolbox and we say, okay, for this one we can use this, what we developed, for this one we can use that. And then we just go in and we automate the workflows one by one, end to end. So I think that's like the difference. What we try to do is like not automate part of the workflow, like for example, slapping voice AI only on one portion of the workflow. We try to do it end to end. And by doing so, we can actually quite easily calculate the ROI, and then we just charge a percentage of that ROI to the customer. So we do outcome-based pricing, where we say like, hey, we're gonna save you, let's say $1,000, and we're gonna capture $100 for each executed workflow end to end. So like we only charge when we succeed in executing the workflow end to end, and then we charge a portion of what it would actually cost the customer. So that's what we are doing.
Very interesting. And since you mentioned AI, let's dive in because that's what we're here to talk about. So big term, a lot of meanings, chatbots, voice agents, machine learning, whatever you want to call it. I'll toss it to the group. So how are you using AI in your companies? And I'm curious if it's more on the user experience side, so in the product itself, or internal ops. So we'll start there, and we're going to spend the rest of the conversation here.
The question is more easy to answer where we're not using AI anymore because the list is shorter, right?
Start there then. That may be a reasonable way to think about it.
Look, I think from our side, I'll focus on where we are using it that is directly impacting those results, right? Because there's indeed lots of AI in internal ops and in across the product. But so Awell has both internal native AI, which has two levels. Which the simplest level is the action. So think of that as I need to summarize a document, or I need to generate a message, or I need to categorize an incoming message. And so that's kind of more like a dumb action that sits somewhere in a workflow that can be used at specific points in time. The level higher up is the AI agent who gets instructions and a set of tools, right? So classic, it is, you need to try to enroll this patient in a new program, and you get access to Twilio for text and Mailgun for email and a voice AI, technology. And you have, within a week, you need to outreach 3 times at different times of the day. And then that agent is off to the races. Transparently, that agent, that Awell agent part that we have is not at scale with Awell. So very transparently, the actions are at scale. And then the agents are, we're learning a lot at this point in time. The other part that is at scale is Awell orchestrating third-party agents, right? So many people or many organizations are procuring, for example, voice AI agents, but those voice AI agents need to be orchestrated, right? One of our customers call it, what's bossing around the voice AI agent? You need to call the patient at, 2 p.m. exactly, and then 2 days later at, 4 p.m. if they weren't able to be reached out at that first attempt. And if it's voicemail, you need to write it back to the care team for a task so that they can pick it up from there. So all of that orchestration, let's say, is handled by Awell, and then the voice AI agent does the actual conversation. And so that is running at scale today with literally thousands of calls on a daily basis that we orchestrate. So those are kind of the big buckets, right? So actions, agents internally, and then third-party agents that we orchestrate.
Nice. Ed.
Yeah, I'll go next. Yeah. So the way I think of it is this is from a non-technical person, from a clinical person. So I'll describe the best that I can, I know of.
We have technical skills, Ed. They're just different technical skills.
That's totally true. You and I both know as internal medicine docs. So it's multi-layered. And so it starts with speech to text and voice understanding. And I'll note that it's, Nabla can support over 35 different languages, so it's multilingual, which is important for our mission to support multiple different types of encounters and be culturally competent as well. And so the speech to text, with the text in hand, that's where the AI LLM models kick in, where there is clinical reasoning and summarization of the discussion between the patient and the clinician. And so taking that and using multiple models within that to create a fine-tuned note based on the different sections within the note that we typically write within the subjective, objective assessment and plan of a typical SOAP note, or the various templates that we have based on the particular specialty that might be involved as well, because we know that each clinician or each different specialty may have different flavors of the notes that they want to write. Like a pediatrician might write a well child visit. They might write a note for a acute visit, write a note for, different stages of development within the child that they're seeing. A cardiologist may have a new patient visit note as opposed to a follow-up note. And so based on the different templates that the clinicians are using, there'll be different parts of the technology that will shape the note in the way that they want the note to be shaped. And even within that, within a particular specialty, we know that each clinician may want their note to look differently as well. Andrew, as an internal medicine physician, you write a note in your voice. I write a note in my voice, and I often want that note to reflect my thought processes, my style. And so our technology allows the customization of the note to be within the voice of that clinician as well. And so all that kind of put together is how the note is produced. And on top of that, there are LLM models that are looking at the accuracy of the note, sort of adversarial models to make sure that we're not hallucinating, we're not putting out output that wasn't discussed, and in the end, kind of put that all together. We're also building additional functionality within the product, not just within note creation, but also around things like clinical nudges to ensure that we're asking the detailed questions that we need to ask for clinical care, as well as being coding compliant. And then coding as well around ICD-10 codes, E&M codes, things like that. But in the future, I can envision even more expansion beyond that, in looking at all the different workflows in which a clinician is faced with that is really clerical in nature and not really clinical in nature. And then using the AI models to help with all aspects of that administrative burden that clinicians face today.
Question for you. How old is Nabla? And this is a pattern I've recognized is companies that are like 3 years or older are incorporating AI, whereas companies 3 years or younger are AI first and native. And so I'm curious, because your product seems like it always needed to have AI in it. How old are you? How long have you been working on it? Just curious.
It's actually an interesting history that I won't get into exquisite detail in, but the company itself is around 6 or 7 years old.
Okay.
Um, I, I have teenage kids. Anytime I say 6, 7, there's a little bit of angst in me out there. But anyway, so the company started as a digital health company caring for women's health.
Okay.
And that was critically important for the history of the company because that was how we understood clinical workflows and what it meant to be a digital company. And so some of the data that was collected during that period of time when we were sort of almost a care delivery organization helped form the foundation for what was to become what we are doing here at Nabla today. The product itself, in terms of the ambient DI product, has been around 3 or 4 years. A little bit before the explosion around
Sure.
ChatGPT. I would consider us a AI first company.
Nice.
I also have a quick follow-up question. So do you allow your individual users to define their own style and structure of the note, or is that something that you as Nabla do on behalf of them when they ask for it?
Yeah, no, so I mean, you know this well, Thomas, in being in the industry here, is that every organization that you work with has different requirements.
Mhm.
And certain organizations want a very structured way in which the notes are produced. And in that case, we can sort of bring that out for those organizations. Other organizations want the flexibility of the clinicians to be able to have their own voice around that. And so even within the product, there's the ability to um, add what we call custom instructions. And so that's basically every single section of the note. You can instruct the AI to write the note in such a way. It's kind of like prompt engineering, even within the product itself, to have those custom instructions to shape the note the way you want to. And individual users can do that on their own.
So there's no standardization inside.
Well, there can be. We can force that upon an organization if we wanted to, if the organization wanted to do that, or we can allow the organization to shape it the way they want to do it.
So what
Thomas,
does the customer base skew towards?
Oh, I'm sorry, I missed that.
What does the customer base skew towards, standardization or not?
Oh, I think it really depends on the organization. I think probably a lot of organizations want that flexibility for their clinicians, but I think it also I think depends on the size of the organization. I think the larger enterprises typically allow the flexibility within the clinicians, and the smaller organizations out there want a little bit more standardization.
Thomas, every physician thinks we should standardize the way we do things to the way that I do it.
Exactly.
That's right.
I wonder if the smaller ones have one dominant person that gets to tell everyone else how to do it, and that's why they have to standardize.
Well, it's one of the core insights of CareOps, right? Instead of talking about standardization, just talk about continuous evolution, right? Then you don't have all of that angst around standardizing around one thing, but you can just get going and then evolve over time so that everybody gets their opinion incorporated, right? Yeah.
Rik, at Sword, how did you incorporate AI first in the company? I'm not sure if you were there for it. Was it back office first, kind of internal ops, or do you put it right in the product right up front? I'm curious, as you know, companies a little bit more of an established company, a little bit older, like where people go first for those that are kind of still on the outside of the journey.
Yeah, good question. So in the beginning, it was actually patient facing, as if I recall correctly. So like as I was mentioning, we started with the digital physical therapy, and that was using like a lot of the old school machine learning, computer vision type of models to give real-time feedback to members. So it's like, hey Andrew, you need to squat deeper, or hey, you need to do this, or you
I
need to
hear
do
that a
that.
lot, actually.
And then they kept on adding more capabilities, like they added a voice AI layer using text to speech and speak to text vendors that like allows the member to talk to it post therapy session. And so they kept on adding more and more of these capabilities. And then obviously once ChatGPT was launched, they accelerated that. And then also I think what's very unique about Sword, even if they are a 10-year-old company, like the push to become AI native really comes from the top. like the CEO is pressuring literally every team. Like whenever we want to hire someone, even if you're like 1,200 people, it's always like, are you certain that you need this role? Can you not do part of this with AI? What workflows will be they working on? How efficient are they? Like we have like an insane focus on like efficiency, and like everything that we can automate, we automate, and we do it through like cloud code, for example, is used by almost everyone within the organization, and something stupid as like scanning for RFPs you can do it with AI as well, and most people don't even think about those things. Like with cloud code, it was literally like one shot prompt. Hey, from now on send me a daily report of all the RFPs that are published in those countries, and give me an information about like if we are eligible for the RFP or not. Like one shot, and like all of these things every day we have the team pressuring like every workflow that you do twice, you need to find a way to automate it. So that's like it started from a member facing perspective, but now internally over the past 2 3 years, it became an insane focus area as well. Happy to go dive deeper into more of the patient side or the internal side, depending on where you want to take the conversation.
Yeah, let's keep diving in. We were, talking about clinicians. How are you all incorporating clinicians of all stripes in developing and using your product? Both sides, both the making of it and then trusting to use it. I'm curious what the adoption curve was like a year ago, 2 years ago, now.
Yep. I can start. So maybe on
Sure.
our side, so I'm obviously a nurse by training, so that helps. I will never claim that I was like a good nurse at anything, but I think it helps understand how broken the workflows are. Then we also have, for example, a clinical director that we hired for Zero Intelligence specifically. So like all the external products that we put into market, it's always validated by clinicians as well. And then internally, we obviously have a very big clinical team. Every division has a head of clinical with their own clinical people under that as well. And beyond that, I think what we really try to do is bring our engineers into the actual workflows, which is often something that is skipped. And I think something that you're right about as well, quite a lot with like the shadowing and all of it. So for example, last week I went to a hospital in Europe and we brought 4 engineers, which is extremely inefficient, and also from a cost perspective, some people within the org questioned the ROI, like why do you need to send 4 engineers to this hospital? But the impact is very significant because they spent 4 days or 3 days talking to literally everyone on the floor. So we started by talking to the leadership team to understand the vision. Then we spoke to their direct reports. Then we spoke to their direct reports. And then eventually we spend most time with people that don't have any direct reports because they're the ones doing the work. And how different the vision is from like the first person that you talk to, so the leadership, and then the people on the floor, it's like insanely different. And like every time we spoke to someone in the hospital, like I kept getting text messages like, how is healthcare still working? Like one stupid example, it's not stupid, it's just actually sad. They had one system where they captured all the people that had died, so are not like alive anymore, and then they had another system that doesn't talk to that system with all the schedules. And so every year in January they need to manually go through all the patients that have an appointment to check if they are still alive, and every year they are able to capture between 2 to 4 months of appointment booked, like of people that receive calls, emails, mailers on like, hey, you have an appointment. And like, of course, like this is Europe, we don't have like Epic owning the entire ecosystem. So like those systems don't have APIs. It's like, I don't know. Like, what I saw, I was very, very surprised. And yeah, bringing them to the pain, I think, is the only way to get there.
So to answer your question of how healthcare works, the most pejorative description of my profession of internal medicine is cheerleader for the neutrophil. So the short answer is, I don't know, our bodies are pretty tough. They can take care of a lot on their own. And we just help from time to time. Ed, you obviously work very deeply with clinicians as your customers. Thomas, you do as well. But I'm curious, what's the Nabla experience been like on both the development side and on the kind of rollout with clinicians and their getting their feedback and trust?
Yeah, I mean, so the core customer that we're trying to serve are the clinicians. So it'd be silly of us to not involve clinicians in development of our product here. My job exists because we need to make sure that clinicians are at the forefront here in working together with our development teams and our technical teams to develop a product that works for clinicians out there who are using this. And that's why we continue to build our internal team of clinicians so that that clinical input gets incorporated, baked in to the product from the get-go. But our internal clinical team is a very small subset of clinicians that I would say that are actually kind of involved with the development of the product because every person who is using Nabla out there has the ability to provide feedback. It's built into the workflow as well. And whereas sometimes when you click provide feedback, it goes into some never land somewhere. We actually have individual real people looking at every comment that comes back, and we take that feedback as a gift for allowing us to continue to develop, improve, iterate, and build new features into Nabla. So I would say the tens of thousands of users out there who are clinicians providing us feedback are part of our team, so that we can understand where we're hitting the mark and where we have areas of improvement to make. And the way I think it is, it really is about trust, trusting what we're doing, and trusting the outputs that we provide, and it's hard to gain that trust, and it's easy to break that trust. And so that's why we pay very close attention to everything that we're doing, as well as around the transparency of our current limitations, and as well as the transparency of our product feature roadmap. And so talking with individual users out there, talking with large health systems, understanding their needs, from the clinician standpoint is all baked into the process of how we continue to iterate on what we're doing.
Thomas.
Yeah, so we are a bit different because Awell is not a product, right? That we are essentially a platform, and the product is created essentially by our customers. And in some cases, our customers ask us to do that, right? And in that case, we're very much like Ed and Rik, where we get into the organization, understand the problems, and we get the flows live that need to solve their problems. But essentially, we offer the toolkit so that our customers can validate, can test, and can essentially create their own product, right? And then to Ed's point, this is a learning from early on, is that every care organization really has its own requirements, and if you sell a product that is difficult to customize, or you can customize only very little, then you're actually forcing sometimes a square peg into a round hole for these organizations. And that's the case with a lot of off-the-shelf software. And so Awell is on the other side of the spectrum. You have very high flexibility in combining all of these building blocks in exactly the way that you want them, with the logic that you want, with AI, without AI, with the stakeholder set you need. I mean, literally for us, some customers have literally the same stakeholder, but they call them differently, right? And they need to see that their name of that stakeholder in the workflow. But that's obvious, because that's how their teams get organized. And so, so long story short, everything that is shipped on our platform has kind of been built, conceived, and validated by our customer base, which by design involves the care team. And it's more than just the clinician or the doctor. That's very often there are nurses involved, care managers, care coordinators, from the bottom layer to leadership level.
Rik, I think you're gonna have to publish the Cloud Code algorithm to get RFPs. So we've seen a bunch of comments around that. So leave it up to you.
I will productize it and generate a SaaS subscription that will allow me to get $50 per.
That's how we do it.
That's what you
Thomas,
always
have you ever heard of Conway's Law?
Absolutely. Yeah.
That's what you do.
Shipping the org chart. Absolutely. Yeah.
Org chart determines product. All right, so let's get into the real depth and the real stories. Give me some painful lessons, painful stories, screw-ups you want to share, things that went horribly wrong along the way that were helpful and instructive, so others can learn from each of our experiences. And I'll leave it to the bravest to see who wants to go first.
I can start. Maybe one thing that I learned the hard way is a few things. So first, it's like how capable humans are. Like the human brain in itself is so freaking smart and so very creative. And like whenever you look at someone doing the work and you think like, okay, that will be an easy task to automate or augment with AI, then you go into the weeds. It's like, damn, this human brain is pretty smart. And so to give you a practical example, we were launching a voice AI agent that was focused on like doing eligibility checks. So like it needed to ask first name, last name, date of birth, like all of these typical things. And so in the beginning, we gave the agent from prompt engineering perspective a lot of flexibility of like you can go back and forth between checking the first name and then if they have a question in between, you can ask that question, you can answer the question. And so that yielded to like a lot of errors because like it lost in where they dropped in the conversation, it forgot to ask the remaining information. So then we made it more strict. So like we say, like once you go into checking the patient information, you cannot go back. So whenever they ask a question, you say, okay, we will answer the question, but let's first finish this thing. But then we got the feedback from the customer to say like, hey, but this is a bit weird of a UX, right? Because I'm filling in my information. I have a question. You should be able to answer that question. And so what we ended up doing is spending a significant time and resources into like educating the customer in itself. Like one, all the demos that you see online that people pitch you, it's like pitch perfect. Reality is not like that. You can break their agent within 1 minute if you try. So like those agents are not humans, and so that's like my main ask to do with the entire industry is like stop making them feel like they are humans and they are as smart as we humans will be, because they are not. And if people say they are as smart and you have reinforcement learning and learning from every interaction, like in most cases that's all bullshit, and it requires a lot of human work to make them improve. And then the second, it's like we need to get to a bar of like good enough with AI, and that's what we spend significant time on right now. It's like don't expect human level quality, although it can get close from like a conversational perspective with the voice and all of it. But like if you drop in mid conversation like a question while you were collecting information, if you don't have the right guardrails in place, it will get lost and it will make mistakes. So like you will need to tie it up quite hard to make it work, but that means that it will not be perfect from a human quality perspective, but still it will get the job done. It will still be a good UI, and instead of waiting 2 hours before a human picks up the phone, they will get help in 30 seconds. But that's my hard learned lesson. Is like you cannot put the human brain into AI at all at this point, and you will need to accept the downsides of that.
Thank you. That's interesting framing. I often hear the opposite, which is people expect perfection out of AI as well, which is a mistake because we don't expect it out of people. And to hear even further, like, don't even expect human level performance, just expect faster, more available, lower level performance. It's a good trade-off.
Yeah, so from our side, so one of my big learnings, but in hindsight, it's obvious, is that actually the failure modes are still all the same, right? So I'll give you a couple of examples. For example, post discharge, right? Everything works in a lead up to like to a big launch, and then on the day of the big launch, this organization is not able to upload their file with discharges because there was a difference between how they did it in the pilot, which was manual, and how it was going in production, which was automated, and the service account didn't have the right permissions. Literally, right? So like a couple hours in, nothing is happening. What is happening? It's literally just permissions on the account, on the service account that uploads the files. Another one. This didn't happen in our system, but one of our customers mentioned that it happened in another system where they had voice AI call out at 1 p.m. and then a user had to make a change, sorry, at 11 a.m. and a user had to make a change to make the voice AI call at 1 p.m. But in the UI, there was a drop down for the number and then a separate drop down for the AM PM. And so what did the user do? They logged in, they changed from 11 to 1. They didn't touch the AM PM. So all of these patients get called at 1 a.m. at night. Right? So this is still, I mean, Rik, your point, I love your point because it's true. We're expecting so much from the human brain, sorry, from AI, that, and it cannot match the human brain, but absolutely our learning ongoing is that humans are still most of the time, the failure mode, right? And so that's also where our platform comes in, whereas, we look at what are all of these steps that need to be orchestrated, where you also don't want to be relying on humans to copy files, to, determine things that need to be happening, but that the human actually gets more into kind of an oversight and monitoring role, and instead of, also an operational role, right? And so that is yeah, that's one of the big learnings. I have a whole list of these failure modes, but those are a couple that come to mind now.
There's an author named Craig Allenson, which if you like science fiction and you need to read like 100 books in a series, check out Expeditionary Force. But one of his quotes is, "It's really hard to make things idiot proof because idiots are geniuses at screwing things up in unique ways."
Yeah.
Ed, tell us some of your scary stories.
Well, I mean, I think that the stories that I have kind of all zero in on the importance of workflow. And when you try to add something on top of or outside of a workflow that is sort of natural, that's when you have challenges getting true adoption and then bringing true value. And so what I mean by that, I mean, I can give you a few examples. The first is around early on in the days before there was EHR integration, and where there was more of a copy paste mode in which the note was created, but then you still have to take that extra step. And so the adoption curve significantly increased when you have true integration with EHRs, and we integrate with the big ones like Cerner, or Epic, Cerner, Athena, NextGen. And so our premise is to reduce clicks, not add more. And so when you have the EHR integration within the workflow, that's when you see true adoption. The second example I have is around the workflow of closing out a visit and then moving on to your next patient. And so one of the features that we have within Nabla is patient instructions. So patient level instructions that they can understand what happened during the visit, so they can take it away and refer back to it later on. And if you have a note that takes minutes to create, the patient's gone already by the time you're done having those notes and those patient instructions. And so that's why we learned very quickly that you got to have a very rapidly created note within seconds, so that you can also have those patient instructions you can provide to the patients. And the third example I'll give here is something that we were going down the path around, and I mentioned this earlier very quickly, something called clinical nudges. And that's where we can listen to the conversation and say, hey, maybe you need to ask more details about how long this has been going on, or what type of clinical scenario is involved with this patient. And what we were doing was, and going down the path of, was interjecting push notifications on your phone to say, hey, maybe you want to do those certain things and ask those certain questions. But when the premise of the product is to allow clinicians to be removed from those distractions, having push notifications on their phone was kind of the opposite of what we wanted to do. And so the design in which we were moving down towards that path, we had to sort of shift and sort of figure out what was the best time to interject some of those clinical nudges, not during the heat of the moment when you're talking to the patient, but maybe very shortly after. So before the patient's gone, or before the patient leaves, but not during the midst of that conversation. So those are a few sort of things that we learned along the way, design aspects, the way we needed to shape the technology and the workflow so that it could be very much in line with what clinicians do and not sort of take them outside of that.
We used to use health coaches for that at IR Health. And so they would work on checking the patient out while I was sitting there writing my note, which gave me like a 4 to 5 minute window to remember everything I had forgotten and fix it in real time. So I absolutely understand where you're coming from, how powerful that post-visit synthetic moment is, and why I was also such a bear around everyone trying to finish their notes before they saw the next patient. which I got violent opposition from people about that one. But the amount of things you remember, right?
Yeah.
When you just 2 seconds to think after the person is you're done is insanely valuable. Let's take a couple questions from the audience, and then I'll hit you with my last question with the last 5 minutes. So I'm taking the from Umar. How do you assess when workflow redesign is better than an AI tool fitting into the existing workflow? As Rashika Fernandez-Poulet likes to say, don't pave the cow path. So is disrupting workflow a bad thing? Go.
Well, the most, the heaviest impact on this decision is someone wanting a shiny new object. And that's only half a joke, right? There are organizations out there that understand that AI is the future. I mean, Rik talked about SORT, right? But there are also care organizations where top-down leadership is saying, I want to start solving these problems with AI, even if AI is not there yet. I just want it to be AI first, and then we'll see, right? And so that is definitely a one of the drivers that we see. The other drivers are the following. So one, when it is really important that something happens deterministically from a medical legal perspective, you likely want to have it not AI do it for now, but you want a deterministic if this then that logic flow with some boxes and arrows. If it is, and on the other side, if it is very complex to model in for example in a flow chart or with a modeling language like you have in some tools like Awell, then if it's high complexity and it is not that important from a medical legal perspective, and I'll give you the quintessential example in a minute, then it is a very good fit for AI, right? And that example is, for example, patient outreach to get them enrolled in a program, or what Rik said earlier about eligibility checks, or some of the post discharge. It's a little bit less in post discharge, but let's just take program enrollment or eligibility checking, where you want that agent to be almost self-sufficient in determining, I'm going to use these tools to try and reach out to Andrew to get them on the phone, or to get them through email or text message, respond and fill in this form. And then ultimately the data that is captured, you want to have a human look at it, definitely if it's eligibility check. Or if you do that deterministically, you don't want the agent to make the final adjudication whether it's good or not. That's where you bring in the humans or the deterministic automation. But all of the outreach steps, it's definitely AI ready and AI possible at scale. Yeah.
Yeah, I don't think workflow redesign itself is a bad thing if you can redesign the workflow to be more efficient, higher quality, easier to adopt. But if you are redesigning workflow, which makes things harder, then that's when you're going to run into problems. And so, how do you know you're succeeding around that? You look at your adoption rates. Are people actually using what you've designed and the product that you've put out there? And if the adoption rates are low, or the uptake is low, then you better take a close look at what you're doing. But if things catch on almost organically, even without a lot of effort, then you know that you're on the right track there with what you're doing, and whether or not it's sort of incorporated into the workflow or redesigning part of the workflow. People speak with their feet, and you can quite often understand whether or not you're doing the right thing based on user adoption rates.
To me, my mental model, and I fail at it at least once a week, is like the question that I keep asking my team is like, are we building a winding knocking machine, or are we building an alarm clock? And I'm not sure if you ever read the article, but like in the 90s or in 1950s, I think, like they had window knockers. So like whenever people needed to wake up, they hadn't something like an alarm. So they had people with like a big stick, and they were like knocking on the windows like, hey, wake up, wake up, wake up. And so obviously we as humans, we didn't build like a window knocking machine. We didn't build something that would knock on your window. What we did is we built an alarm clock. And so the thing that I have issues with, which again, I feel that very often, is I talk to an executive, I talk to people on the floor, and we shadow the workflow, and then we just try to automate the current workflow in itself. But in that case, we are building those window knockers because, as you know, whenever you shadow a healthcare workflow is extremely broken. And if you think about it from first principles, it shouldn't look like that, but it's just easy because it's like you have a workflow, we slap AI on it, and tada, we now have an automated workflow. But we shouldn't be doing it, but like change management is a pain point. So like building the window knocker is so much easier than building the alarm clock because it requires so much thinking and so much cognitive load that I don't have. Most people don't have, and most people don't have the gut to convince the executives, to Thomas' point of like, hey, do you want to have the shiny object or do you want to go from first principles and totally rethink your processes? And so I think that's the biggest issue and the biggest complaint that I have about all AI implementations, including some of ourselves. It's like, let's stop building those window knocking machines and like really try to reinvent and build alarms in healthcare. And it will require a lot of clinical thinking and a lot of smart people to fight for this.
Fun stuff.
So this is actually I love your point, Nick. It's not a new problem, right? Because before digital we had paper, right? And so there's also this saying, a bad digital process is still a bad process, but digitalized, right? So we used to have these flowcharts from the whiteboard or from a paper document, and then it got digitalized digitized without AI, and now we're just doing that again with AI. So we're kind of instantiating the window knocker issue. I love that analogy.
This is a question for Thomas. Do you know what a nomogram is?
It rings a bell. It's a statistical tool to put results in something in a big population, right? So
basically, it's a paper computer, right? You put a graph correlating like 2 or 3 lab values, and then you take a straight edge or a piece of paper. Like that's still state of the art in medicine. MDCalc.com is just paper computers put into a web form, and it's brilliant. So like this is what we're used to. All right, last question. I'm gonna Natalie's asked this question a couple times, so I'm gonna let it get in today, which is, can you speak briefly about your governance policies, committees? Do you put your policies out in public? Are they private? I think this is a very important question. This is what I'm working on this morning with Schutzbank itself, of like what's the best way to be transparent about what we're doing and make sure we have everyone's permission and all that. So curious if someone wants to take an AI governance question.
Okay, the webinar is over. We're going to close here.
Yeah.
Well, I can speak to what I've seen at healthcare organizations of what they've done around their area governance committees, and I think in general, it's to be more inclusive than exclusive, to include folks at the C-suite level, including CMOs and CIOs, CMIOs, but also folks at the front line of care. So frontline clinicians, frontline nurses, physicians, even sometimes legal and compliance, so that all perspectives can be included into the thought process around the governance. You also, of course, don't want to be overbearing there, because if you have a committee of 50 people, you never will get anything done. But including the right perspectives will allow you to ensure that you're not missing any sort of having any blind spots. And sometimes even some committees include patient care representatives, so that those voices can be heard as well.
All right. Let's end now. Thank you, everybody. I appreciate you, Awell, Thomas, Carops, for putting this together. Ed, thank you for joining us and sharing Nabla. Thanks for letting me host. Thank you, everyone, for joining. Hope you learned a little something. And I believe we've one more in this series set up for January that we're working on. So stay tuned. And as I have the last plug, check out Schutzbank.com for all your advice needs. Thanks, everybody.
Thank you.
Thanks.
And talk
Thank
soon.
you.
Ciao,
Bye,
ciao.
everyone.